We can't stop fighting because if we do, they'll just take things back. But we have to keep them on their toes. We just have to go public. When I was chapter president, I personally wanted to sue our Medicaid chapter, our Medicaid in our state of New Jersey, for things that were wrong. The Pennsylvania chapter did it. I'm going to go back 25 years. And they won. Now, granted, Medicaid didn't want to talk to them.
Yeah, Florida did, and they won. They got a great settlement.
And then
I don't know where they got the money to sue them from, but they did.
So,
I'm still saying about...
When you look through your consulting company, what is a good ratio of 99213s to 99214s in a general pediatric office?
So it changed. When the CPT rules changed in 2021, to where we now have either use time or medical decision-making, which is made up of data, network complexity of problems, and risk, it changed. I was a big 214 use previous to that. Easily 64% of my sick visits were 4s. Not because my patients were so complex, but I took my detailed histories and I documented it. I took my physical and I documented it. I was audited multiple times going back into the 90s by all the insurance companies, but I never paid a penny back to them because my documentation supported my use of whatever CPT code it was. And I didn't document to get to that code. It was just me trying to be thorough. And back in those days, that counted. That changed substantially. And now I think I have more 3s than I do 4s. I have found consulting for practice around the country, when I do charts for them, they're usually wrong. The doctors either undercode, sometimes they'll overcode. When they've been audited by insurance companies, be it commercial or Medicaid, those audits by the insurance company are wrong easily 20% of the time. I had a practice in Connecticut come to me about 5 years ago. Medicaid Connecticut was going crazy going after pediatricians. Large practice, they audited them. They wanted $600,000 back.
Wow.
I reviewed the charts and Medicaid was right, 80%. So they wound up paying a challenge. So they didn't pay $600,000. So instead they paid about, let's say $450,000. It's a lot of money because that documentation was terrible. Their 4s weren't 4s, they were 3s. So I'm finding more and more, I would say it's probably 50-50. I just did an audit 3 weeks ago for a 3-person practice. It was pretty much even how many times they undercoded versus how many times they overcoded. It's documentation. Listen, I hope we're all had residency training. We all do the best for the kids and we try to do what we have to. But if you don't document what you did in the chart, you're lost.
Yeah, but this is where the problem comes in. How do you do volume to make up for loss in reimbursement? Continue to do the right thing, as Herb said. Seeing a patient for I don't agree with you on this, where you say seeing a patient for a checkup and they come in and they're suicidal or whatever, anxiety, depression. You say, okay, we're not going to do your checkup today. Come back next week, because there's other factors involved in this. There's quality incentive programs that require you to have a checkup. So there's funds attached to that. So you got them in for their checkup. You might as well finish it. I've had cases when a teenage girl came in for a checkup. She filled out the PHQ-9 and she was suicidal.
Yeah, everybody had cases like that.
Yeah. So what my process is, I do the checkup, I order the stuff, then I start entertaining the PHQ-9, talk to the mother, talk to the kid, and then send them to wherever they need to go. If they're suicidal, they're going to the ER. But you should be reimbursing this because they're not just a 10-year-old that came in for a Tdap.
You're right. That's the key word, George, should be.
Yeah.
And with the commercials, you can get away with more using a 25 modifier than you can with Medicaid.
Yeah, but this coming around, and there used to be advocacy on this where it wasn't paid before. Then it was okay as long as you had documentations. The EHRs developed a process where it's easy to document because there's always a documentation. You never wanted to write another note. But now it's easy to write another note. So they should reimburse or pay Dr. Bravo.
They should.
And if somebody has to advocate this.
But that's the A&E. That's who has to advocate, because that's the power of 66,000 pediatricians. But you and I all know, particularly with commercial, pediatrics is budget us to them.
I know that.
but it's significant to us. So that's why we have to fight, which means we have to push our chapters to do it. We have to push national to do it.